Good evening once again. Today's topic is current concepts in the management of swallowing problems in adults. The speaker is Dr. Vidhyadharan Sivakumar. He is the clinical director and consultant at the Head and Neck Center and Hospital, Chennai, and is an adjunct faculty at the Amrita Institute of Medical Sciences, Kochi. Dr. Vidhyadharan did his MBBS from Sri Ramchandra Medical College and Research Institute, Chennai, and his MS ENT and Depend ENT from Raja Mutaya Medical College and Hospital, Chidambaram. He went on to do his MCH in head and neck surgery at Amrita Institute of Medical Sciences, Kochi. Dr. Vidhyadharan has done various fellowships and trained in head and neck surgery and oncology, robotic surgery, reconstructive microsurgery, and sleep surgery in India, Australia, Canada, Taiwan, and South Korea. Areas of specialization include head and neck oncology and reconstruction, laryngology and deglutology, and minimally invasive and robotic surgery. He has over 50 research and academic publications in journals and textbooks, and he has received several awards, including the gold medal in his MSCNT, Best Podium Presentation, and Rising Star Award for work in oncophago surgery in 2019. Thank you, Dr. Vidhyadharan, for readily accepting our invitation to give a talk on marvelous medicine on this very important topic.
Thank you, ma'am.
Moderating the session will be Dr. J. Sendilnathan. He's a consultant neurologist at Fortis Mallar Hospital, Chennai. He's also the clinical lead at the Institute of Neurological Sciences at the Voluntary Health Services Multi-Specialty Hospital and a visiting faculty at Sri Balaji Medical College, Krompet. Dr. Sendilnathan did his MBBS and MD medicine from Raja Mutaya Medical College, Chidambaram, and it turns out that both of them were studying at Chidambaram around the same time. And he did his DM neurology from Madras Medical College. Dr. Sendilnathan has authored 2 textbook chapters and has 6 publications to his credit. His areas of interest include movement disorders and stroke. Welcome, Dr. J. Sendilnathan.
Thank you, ma'am. Thank you for the kind words.
Co-moderating the session will be Ms. B. Padmaja. She is a consultant speech pathologist and audiologist at the Vijaya Group of Hospital, Chennai for over 30 years. Padmaja did her bachelor's and master's degree in speech, language pathology and audiology from the All India Institute of Speech and Hearing, Mysore. She received hands-on training in rehabilitation of cochlear implantees in Vienna, Austria. Dr. Padmaja has counseled and treated many patients with swallowing disorders, and her warmth and empathy wins over the most uncooperative patients. Articulation test in Telugu that Ms. Padmaja developed as part of her dissertation is still used to evaluate articulation in the Telugu language. Padmaja's interests are yoga, fitness, and embroidery, and she's an avid reader and a collector of fiction. Thank you, Padmaja, for readily accepting to join this session. We will value your inputs once the talk is over. Over to you, Dr. Vidhyadharan.
Thank you, madam. At the outset, I would like to thank you and the marvelous medicine team for giving this opportunity to me to give this talk. And it's also nice to see Dr. Selanan. I haven't seen him in many years. And also nice to see Dr. Professor Muthujayaram, madam, which I've met before. So some familiar faces in the crowd. And my regards to Ms. Padmaja too. And I hope she already knows what I'm going to talk about. So I'll just give a brief. Dysphagia is a very big topic, and especially among adults, a lot of causes. And I'll try to make it as interesting as possible, especially post dinner. Most of you have, and hopefully you had a good dinner and good swallowing episode. So we'll start with the talk, ma'am. I'll just go to my screen and I'll stop the video of myself so that it helps to easy viewing of the videos. Otherwise, I have quite a lot of videos.
Yeah, it will preserve the bandwidth. I agree. Go ahead. No problem.
The bandwidth as well. Thank you, ma'am. Okay, so I've renamed the topic as dysphagia management in adults, or demystifying dysphagia, and this would be the content of my talk. Basically, I'll be talking about the prevalence of dysphagia, the etiology and causes of dysphagia among adults, a bit of pathophysiology, the long-term consequences of it, and also the methodology of how we identify, screen, and manage dysphagia, and the importance of a multifunctional team in the management of dysphagia, as it is in almost every aspect of medicine nowadays. And also a few cases of personal experiences, which I found a bit unique, so that I'll share this. And So eating and drinking should be a pleasurable experience for everyone, no matter who cooks it or what type of food you eat. And good nutrition and hydration is essential throughout our lives. And in case of any neurological problem or cancer or any illness, our body needs to work extra harder to recover from it. And for that, we need good nutrition and hydration. And if only you are able to swallow our food and our liquid safely, we'll be able to maintain this. So meal times are more than just nutrition, and on a non-medical and a social impact, they're less enjoyable when we don't enjoy our food, or when you have to restrict our food to a certain particular consistency of food. And it's very important that when we have a problem like this, we need to identify and we have to get it managed appropriately. And social eating, nowadays, that's also a bit less with the advent of TV, serials, and all the WhatsApp on the phone. We end up isolating ourselves in eating. But those days, meal times used to be a very social occasion, and it's still a common thing you see in weddings and parties. So when you have a swallowing dysfunction, it's very difficult to have that social interaction also. And this, if somebody has a swallowing difficulty, it will make the meal times, they dread that meal time. They're afraid, how are they going to eat in front of people? How are they going to eat in public? Or how are they going to eat that food? It's not that the person who cooked it, but it's just the food consistency. They may be afraid. They may not be comfortable with one particular food consistency. And when normal food and drink becomes hard to swallow, you end up having choking, or you accidentally inhale the food into the lungs. And this happens very frequently. We'll end up having malnutrition, dehydration, and additional clinical problems. So with this background, I will try to tell about a physiology of deglutition. So the process of swallowing, as such, normal swallowing, requires a coordinated actions of muscles of the mouth, the pharynx, the larynx, and esophagus. And all this are innervated by central and peripheral nervous system. So you imagine that you have 33 pairs of muscles on either side of your throat, 33 pairs, and you have like around 5 to 6 major nerves which help in moving these muscles in a very coordinated action. And the act of deglutition, or the act of swallowing, is generally divided into 3 phases. You can say 4. If the first phase is the oral phase, and that is of 2 types. If you can see in this video, the food is masticated, that is chewed into a powder bolus, semi-solid bolus, and then it's propelled back towards the pharynx. And that is a part of the oral phase. And this is a voluntary phase. The act of actually chewing the food, the teeth act together to grind the food. The tongue helps to hold the food in between the teeth, because when the food goes laterally, the tongue moves it towards the teeth. So the food is nicely mashed down to a bolus. And then the tongue also propels the food backwards. So this way, the anatomy of the tongue is very important. And we need to understand how the tongue moves and how the tongue functions in different issues. And voluntary phase, oral phase is a voluntary phase. And after this phase, the next phase is the pharyngeal phase. And the pharyngeal phase is basically a very important phase. And that's why when we have dysphagia here, we call it oropharyngeal dysphagia. And in this phase, it is basically the oropharynx, the nasopharynx, the hypopharynx, and the larynx all work together in coordination to push this food bolus safely and bypass the airway into the food into the esophagus. So there is coordination between the upper digestive and the respiratory system during swallowing, and this is essential for an efficient feeding process. So in fact, because you end up sharing your airway and your food pipe together, and when you end up not closing your airway, this is the act of swallowing, you aspirate and then you cough. So this is what we tell you should focus on when you're actually swallowing, you're not breathing. That millisecond when the food bypasses the larynx, your larynx is all completely closed, as you can see in this video. So in this pharyngeal phase, you get different valves which close. One is the nasopharynx, where the soft palate occludes the posterior nasopharyngeal wall, and this prevents food from going up through the nose. And the second thing is the epiglottis starts bending down, and then the 2 layers of protection, there's the false cord and the true vocal cord, close. So they prevent the occluding the laryngeal inlet to prevent food bolus going there, or even water going there. And then the post-cricoid area, the cricopharyngeal muscle also opens up, and the food bolus passes down safely. And any lack of coordination of feeding and unbreathing process can result in dysphagia, which includes also changes in the swallowing passage. So this part is usually, if there's a problem, they call it oropharyngeal dysphagia. And next is the esophageal phase, where the peristalsis takes over. There are two types of peristalsis, primary and secondary peristalsis, which safely transport the food bolus down into the stomach. And any problem here, patients can have regurgitation of the food or also painful sensation in the chest. So the whole process of deglutition is of three processes: oral, pharyngeal, and esophageal. Oral can be subdivided into two. That is the oral preparatory phase, where you're preparing the food bolus, and then a oral propulsive phase, where the tongue acts like a piston to push the food bolus back into the throat. Now, what is dysphagia? Swallowing disorders are also called dysphagia, and they're not considered as a disease, but it's actually a symptom of some underlying disease process. So my best definition for dysphagia is what this line would say. Dysphagia is defined as any disruption to the swallow sequence that results in a compromise in the safety, efficiency, and adequacy of nutritional intake. This is the best description I could find, because there are many different definitions of dysphagia. There are two types, as I told. The main types are oropharyngeal dysphagia and esophageal dysphagia. Oropharyngeal is characterized by the muscle and nerve malfunction, the oral cavity, larynx, and pharynx. And esophageal is the disordered movement of the food within the esophagus, as you can see here. And you can have multiple conditions which affect the esophagus and the esophageal sphincter. The prevalence, actually among Indians, the exact incidence prevalence of dysphagia is not very clear because there is not much. Only now the interest has been is there, and hopefully in another few years we'll be able to document the prevalence among Indians according to each disease process. But among American, which most of the publications come from there, approximately 10 million Americans are assessed with some type of swallowing difficulty every 10 million swallowing difficulties every year. And stroke is the most common cause of dysphagia over there. And about 50 to 75%, that is out of 100 people, 50 people end up having some form of dysphagia. And about 60 to 70% of patients who undergo radiation therapy for head and neck cancer end up having dysphagia. That means almost 70% have 70 people out of 100 people who undergo head and neck cancer treatment end up with having some form of dysphagia. And patients with neurological diseases like amyotrophic lateral sclerosis, myasthenia gravis, Parkinson's disease also have dysphagia. And recently, there are a lot of publications where in elderly long-term care or elderly care geriatric centers, we identified there's almost 60% of elderly people have some form of dysphagia or a high risk of dysphagia, because as the aging occurs, there is some changes in that swallowing mechanism due to muscle atrophy. Now, this is a busy slide, but you can see the different prevalence of dysphagia in each of these illnesses. So one is the head and neck cancer, 50%, Parkinson around 80% of the patients. It depends on the type of Parkinson. Is it a static or a progressive? Traumatic brain injury. So this is why helmet is important. So 65% of patients with traumatic brain injury have dysphagia. Patients with severe reflux can also have dysphagia. And this is what sometimes we used to say globus pharyngeus. And sometimes we used to tell them psychological, but now we found that patients with laryngopharyngeal reflux or silent reflux due to gastroesophageal reflux disease can have dysphagia. COVID-19 has also patients, at least 20% of patients with COVID-19 have been having some form of dysphagia. Sometimes it's actually due to the COVID illness severity, or it could be also post-intubation with some dysfunction of the larynx. Now, if you see this whole air digestive tract, you can see from the skull base to the pleura, this whole area we call it the aerodigestive tract. This is excluding the spine, of course. And it is so important because there are so many structures very tightly packed in this head and neck region. And this is rich in having so many different basic functions. We have the function of smell, the function of taste, the function of voice, speech, swallowing, and hearing. So many functions. And if there is one disability over here in any of these areas, patient will have some form of dysphagia. For example, if they're not able to smell properly, they cannot appreciate the flavor of the food, and they will not be able to eat and enjoy the food. And that they would say they don't want to eat that food. They avoid that particular food because they don't have any taste for that. And that could also come some form of dysphagia. If they have some form of tonsillitis or some kind of throat pain, they can have odenophagia leading to dysphagia. As we age, all these sensory functions start decreasing. Along with that dental, we start losing teeth, and we also have saliva. And a tissue also is not very elastic, and there is muscle function decreases due to atrophy. And all these also contribute to some form of dysphagia. So we have the one particular term called press by dysphagia. Now, what are the signs and symptoms of dysphagia? If you have a patient who takes extra time, longer time to swallow and eat their food, they take more time to eat the food, you have to suspect whether they have some form of dysphagia. If this patient is constantly drooling and not able to manage the secretions orally, and they're not able to chew their food bolus, then they may have these are signs of dysphagia. If they're after swallowing, if the food is still remaining, some part of food is remaining in the mouth, we call it oral residue, then we need to figure out why that's happening. And very commonly seen in neurological patients, especially recent stroke, they'll have one thing called oral holding. They end up holding the food in their mouth and they won't swallow the food, and we'll keep trying to push them. And this is a bit of a problem because the carols try to feed more food and the patient will end up aspirating. If they have inability to maintain lip closure or a lip seal, this is maybe due to cancer surgery or a facial nerve palsy, and this can cause an embarrassment in public where they end up spilling the food on their shirt or the blouse. And they also have food leaking into the nasal cavity. This is very commonly seen in cleft patients and patients with the soft palate weakness. Some patients complain of food sticking to the back of the neck and also having food sticking in the chest, and that we call it a globus sensation. And also there's a change in voice quality. If the voice after eating sounds very gurgly or wet, then we know that the patient is retaining some food in the back of the throat. So this also is signs and symptoms of dysphagia. Further, more severe signs are coughing. Constant coughing, clearing the throat shows that they may having some form of aspiration, and they are having recurrent visits to the hospital due to aspiration pneumonia or chest infection. There are changes in eating habit when the patient starts avoiding one particular consistency of food, and you start to investigate and figure out why. There's also weight loss, malnutrition, and also dehydration. These are the long-term effects of dysphagia. Children as young as this also can have some form of dysphagia, and most of them will be having syndromic issues. Why is dysphagia identification important? Because it's associated with increased morbidity and mortality, and also related to a very various level of complication from dehydration, aspiration pneumonia, malnutrition, choking episodes, bronchospasm. Imagine if a patient is having loud cough in a restaurant whenever they're eating, and everybody starts looking at them. That's also kind of social embarrassment, and it ends up making them like a social cripple. They cannot enjoy a meal or eat in public. And long-term effects, when there's not enough nutrition, they can have muscle wasting or sarcopenia, and they can all be physically debilitated. This can also give rise to poor wound healing and reduced tolerance to any further medical treatment, especially in cancer patients where they cannot withstand some chemotherapy or radiation or surgical wound. And this is a vicious cycle. Because of the disease, because of the aging, they have inability to eat or drink, or they have fear of eating. Their whole behavior to food changes, and this is due to having reduced food intake, or then they got malnutrition and dehydration. And this cycle keeps going around and around until we figure out what exactly we can do to help them break the cycle. Pediatric dysphagia, the main causes is different from those of adult patients, and there are also behavioral issues. So children with autism spectrum disorders can have behavior related issues, and also sometimes proprioception, or when children, you don't allow them to explore with their mouth, that is, they put stuff in their mouth when they're young, 2-year-old, they may end up becoming picky eaters as they grow older. So these are the problems, and there are multiple other structural and congenital issues which I will not go into the topic, but I just want you to be aware that the children do also have feeding and swallowing disorders. Now, coming a little bit of neuroanatomy and physiology, I just want you to understand so much of neural network is involved in coordinating these muscles. So the actual cerebrum and the midbrain helps in coordinating these muscles together. And usually what happens is there is a peripheral stimuli in the oropharynx and larynx. When the food goes from the voluntary phase to the involuntary phase, that is the pharyngeal phase, from the masticatory phase, when you when you have finished chewing and made the food into a semi-solid or liquid bolus, you try to propel the food backward to the back of the throat. The involuntary phase or the pharyngeal phase starts over. And in this thing, all the mechanoreceptors in the throat get stimulated, and all the afferent impulses go to the brainstem swallowing center, and over there there are two groups of nerves which process and then send out the motor impulse of what each muscle should do. And all this need to work in coordination to help our normal, the safe swallow. And this is the important structure in the brainstem where these two swallowing groups are present. Is usually we call it the central pattern generator. I won't go too much into detail of this, but you can see I've just mentioned the oral phase, that is the voluntary phase, how much of neural network connections, all the afferents and efferent connections between the brain stem and the spine is important. And this is what I was mentioning. In the tonsil, in the throat, there are so many mechanoreceptors. And these, when you're eating something, just feel, if you try to put a warm food in the back of the throat, you will feel the most sensation around this area, temperature, touch, pressure, all this. And this will relay the afferent impulse to the brain saying that be prepared, this food is coming in. How you should manage and swallow this food safely. All these motor impulses start coming out. And also saliva plays an important role. This helps in lubricating the food, and also the adequate amount of saliva is very helpful to propel the food backward. If there is no saliva, the patients will have problems with the teeth, enamel will go, and then the teeth will fall off, or they'll have cavities, and they'll not be able to chew, and they will not be able to lubricate the food, and the enzymatic process will not work. With regard to pharyngeal phase, same thing. A lot of different neural networks, and also important, the larynx plays an important role into protecting the airway. So if there's a laryngeal dysfunction, the patient will have high chance of aspiration. With regard to esophagus, in the esophageal phase, there are two different types of nerve supply for the different muscles, the circular and the longitudinal muscles, and this helps in the normal peristalsis. And in this whole algorithm of how the cortex and the brainstem swallowing centers and the motor nerves all work together, there could be at different levels, diseases can affect and cause some kind of problem. For example, in a stroke patient, there could be a cortical stroke or a brainstem stroke. Usually brainstem strokes are a bit more severe in regard to dysphagia. And a patient with myasthenia gravis, the peripheral swallowing muscles can get affected. So any neurological condition can affect some part of the pathway. And with this, if you understand this, then we can actually prognosticate and decide during rehabilitation how long the patient will take to come back to normal swallowing as such. And that way it will be helpful in the counseling of the patient and the family. So when you encounter a dysphagic patient, these are the usual steps we follow. We take a detailed history. If it's a neurological history, we go very deep into that and understand what type of stroke or what type of neurological problem. If it's a kind of a cancer or a head and neck tumor related history, we find out what type of treatment they've had. Is it some kind of radiation treatment or surgery? What type of resection has been done and what nerves have been compromised? We also keep an eye on understand the patient's mental status, the cognitive status. If the patient has a good cognitive function, they understand what we do, and we can also help them with the actual rehabilitation. And also we do a lot of test swallows on the bedside. So besides the history, a detailed physical examination would involve examination of the neck, the cranial nerves, and laryngeal elevation and velopalatal movement, and also the gag reflex. We also do different types of swallowing test, water swallow test, or repetitive saliva swallow test, cervical auscultation test. And there are a lot of many different protocols to identify this. Posture is very important. When you're eating, you need to be able to sit upright. And if you're able to maintain that upright posture, then you will be able to help get the use of gravity to push the foot down. If it's very difficult to balance and to keep the neck straight, then you're going to have more chances of risk of aspiration. We also see the patient's nutritional status, because if the patient is not able to take adequate volume of food, then we need to supplement with some type of tube feeding. Cranial nerve examination is very important, but especially the lower cranial nerves, to understand how each of these muscles function. And there are a lot of screening and assessment tests for screening for different types of dysphagia. Neurological dysphagia, the cancer-related dysphagia. So for neurological, we have the Toronto bedside swallowing test. For cancer-related, we have the MD Anderson dysphagia. So different types of dysphagic screening tests are there. The commonly used scale for assessment we use is a penetration aspiration scale, just to understand whether the patient is actually aspirating or at a risk of aspiration, and then we grade the patient. We also, if the patient is dependent on a Ryle's tube or a nasogastric tube, we have a different set of scales to find out that too. So once you've done the history, we have taken the history, we've done a complete physical examination, we got an idea about the patient's functional status, then we need to confirm these findings with the instrumental evaluation. So the commonly done test for swallow rehabilitation is usually a FEES. It's fiber optic endoscopic evaluation of swallowing, or a video fluoroscopy. It's also called as modified barium swallow. Sometimes pharyngeal manometry is also used. Fiber optic endoscopic evaluation of swallowing is usually done as a bedside test, and it can be done in the outpatient clinic or in the bedside. It is helpful in assessing the risk of aspiration in patient dysphagia. You can also assess the whole of the larynx, the pharynx, and you don't need to transport the patient anywhere. You just need to take them and use a flexible camera, and this is how the camera looks, where you put through the patient's nose, and you can have a good view of the voice box and also the oropharynx and the hypopharynx. We assess the patient's laryngeal mobility, the mobility of the cords, the laryngeal sensation, the movement of the upper esophageal sphincter, and then we try different types of food stuff, colored food stuff, to see how the patient swallows. When the patient swallows normally and the muscles are all working, the food should be completely cleared off, like you see in the video, and you will see a white out. That means when everything is contracting, the whole the camera view is obscured for a small time, and that's a good sign. We need to check that. So we assess the anatomical, physiological. We do an anatomical and physiological assessment of the whole mucosa, and this can be done multiple times. So, and you can also get feedback by introducing some kind of therapy and seeing how it works in real time. The advantage that it is less expensive compared to the other tests. There's no radiation exposure, and of course you can do a biofeedback. It has a high level of sensitivity for aspiration and penetration. The only problem is you cannot see the oral phase because it goes to the nose. The camera goes to the nose, and you can see the pharyngeal phase, but you cannot see the oral phase and the esophageal phase. So that's where the video fluoroscopy comes in. Video fluoroscopy, or the modified barium swallow, is considered as a gold standard diagnosis. And here the patient is required to swallow liquid or solid barium, and we get a real-time image as the patient swallows. This also helps to detect microaspiration, and also you can see all the three phases in it. Here's a lateral view of a video fluoroscope picture. The patient is swallowing some food coated barium, and you can see that how they swallow. You can see the structure of the spine. You can see the upward movement of the larynx and also the movement of the tongue. But only problem is you need a fluoroscopy unit, you need some radiopaque contrast, and there is some amount of radiation exposure. And this is an entry view where you can see the whole esophageal periscope, the whole view of the esophagus. Now, this is a dynamic study as compared to a regular barium swallow, because you can see every single movement, every single muscle, movement of the muscle, and sometimes with just pictures you may miss this one. We tried different food boluses from 5 ml to 15-20 ml of different types of viscosity to see which has any problem during the act of swallowing. The advantages, you can see all the three phases. The disadvantage, it has some of the radiation exposure. Now, coming to the importance of the treatment, dysphagia management is evolved into just one particular physician to a full team. The people who are involved are mainly speech language pathologists associated with ENT surgeons who specialize in laryngology. It's a branch of ENT. And also there are cancer specialists, the pulmonologist, gastroenterologist, and the dietitian is most usually involved. So the reason for the team is that because of this vicious cycle, patient has dysphagia, end up having poor oral intake, end up getting malnourished, then the muscle mass has come down, sarcopenia, and again, they're not able to eat. So and then end up being tube dependent and going round and round. So with the team, you're able to address at each point of the cycle. So the dietitian can help with the nutrition support and food texture modification. The clinician or the medical personnel will be able to manage the primary disease, and the speech and language pathologists help with the swallowing muscle strengthening. And this helps by they have two types of different therapies, and then they apply that. So with this, the team, we are able to reduce the swallowing dysfunction, the sarcopenia, and the decreased nutritional intake. And I was telling you about the other problems which are consequences of dysphagia. There's high risk of fractures, malnutrition, edentism, dental diseases, and low muscle strength. So coming to swallowing therapy, there are mainly two types: rehabilitative and compensative. Compensatory. These are basically usually performed by the speech and language pathologists, and they rehabilitative type of therapy is indirect swallowing therapy. What we do is that we try to uh, re uh, re-improve this existing muscle strength and try to get them back to normal. Mostly it happens in neurological patients. Compensatory is that there is some part of the anatomy which is disrupted or not there, and we use the other anatomy to help with the swallowing therapy, and that becomes compensatory therapy. There are multiple different exercises used by the speech language pathologist to help strengthen the muscles, and these are a few exercises. I won't go too much into detail, but these exercises help with different structures from the oral cavity, the oropharynx, and for this is a lingual protrusion against resistance to helps with the tongue-based strengthening. There's an effort for swallow. This focuses on the strengthening the constrictor muscles in the throat, and the Shakir exercises. This helps in the strap muscles of the neck and helps to strengthen the laryngeal elevation. Supraglottic swallow, you might have heard these. Helps to voluntarily try to contract the larynx and close off the laryngeal inlet so that the food can bypass the larynx. Helps in patients with laryngeal dysfunction. Supraglottic swallow is mostly taught to elderly because they understand it better. And this is basically to increase a baritone pressure along with the supraglottic swallow maneuver. Head turn is also small kind of compensatory maneuvers where one side of the neck or there is weakness of the muscles of one side of the neck. So use the other normal muscles to help with the swallow. Chin tuck is to help with open up the upper esophageal sphincter. So every maneuver exercise has some kind of rationale to help with this strengthening the swallowing mechanism. Now coming to a few cases which I thought would be interesting. I'll start with dysphagia of neurological origin and then go into head and neck cancer, and then I conclude the talk. So here is a patient, a 53-year-old male who's a hypertensive diabetic. He had a history of road traffic accident followed by loss of consciousness. He was diagnosed with diffuse axonal injury and left temporal acute subdural hemorrhage and subarachnoid hemorrhage. He recovered from that, and he also had a zygomatic facial fracture, which was treated during the surgery time. But he ended up having a left vocal cord palsy and was PEG dependent for a long time, PEG and tracheostomy tube dependent for a while. And he was then referred to us with a history of cough with expectoration dysphagia. And this is the first video I see. You can see the when you go through the nose. This is the video on the left hand side. You can see the endoscope going through the nose, and we are assessing the throat. You can see the soft palate. The right side soft palate is more mobile as compared to the left, and there is an atrophy of the left soft palate muscles here. And this is a problem because whenever he swallows, he'll have nasal regurgitation. So we need to figure out how to get him to move. As we go down, we went down to the larynx. You could see there's a lot of pooling of saliva in the hypopharynx, which is the portion behind the larynx. And you can see one part of the vocal cord not very mobile. That is the left side. The right side seems to be moving, and the left side is bowed a bit. And this is very prone for aspiration. If he takes more than necessary amount of water through his mouth, he will aspirate and cough. This is him a few months later with the swallowing therapy. The amount of pooling of saliva reduced. All we did is just rehabilitate him with exercises, and we ended up decannulating him, and he could also talk. But what has happened in long term, there was some atrophy of the constrictor muscle because that did not completely recover. And now we are planning for a medialization surgery for this vocal cord, and we also bulk up this area so that the food doesn't get pocketed. So post rehabilitation, he's been doing very well. He's off his PEG tube, he's off his tracheostomy tube, he's able to eat well, but there is food dust collected because of this hollow, because of this constrictor muscle, which is weakened off. So this is how the swallowing therapy can help. And this is him again, still awaiting the procedure. And you can see, even though with exercise, the paralyzed side is still become very weak. And you can see that because it's more lapsed, that it seems to be fluttering a bit in the whenever he tries to vocalize. I don't know whether you can see that this part is less bulkier than the right side. Yeah. So this is the weakness of the soft palate. I've already finished that. So I'll go ahead. So in this particular situation, we call it glottic insufficiency. That is, one part of the vocal cord does not work. So this usually common in head traumatic head injury. There's a traction during thyroidectomy also that can happen. This problem. The patients who had cervical spine surgeries, the rectal nerve can be not be working, and they can have vocal cord palsy and skull base resection. Also, prolonged intubation. That can now. So in these kind of situations, patient has aspiration or dysphagia. They're evaluated by the speech pathologist for aspiration with the test we did, and also sometimes it's referred to the ENT surgeon. The speech pathologist, along with the team, plan the compensatory different types of maneuvers, and if that doesn't work, then we try some kind of a medialization surgery. And these surgeries, we call them now globally as phago surgery. And so these surgeries is very common. What we do is the injection laryngoplasty, where we inject some form of a filler to bulk up this paralyzed vocal cord to help achieve good glottic closure. This can be done with hyaluronic acid or Restylane, or sometimes with fat. And this is also done as an office procedure. Here's a procedure where we end up injecting some fat into the paralyzed vocal cord. And this helps to bulk up the vocal cord. So how do we harvest the fat? We harvest the fat in the patient's abdomen, the belly fat, and then that's mixed with insulin to help prolong the stasis of fat within the tissue, and then that helps of bulking up and medializing the vocal cord. This is a very simple procedure, and this is the vocal cord post pre-laryngoplasty. You can see there's a bubble of saliva, because that means the patient can aspirate. And these are the patients who you feel their voice will get better because the opposite vocal cord compensates, but they are the ones who would end up having occasional cough, or whenever they drink water, they have a coughing episode. And this is the vocal cord. You can see a good closure over here after the injection, and you can see the fat in the layer of the vocal cord there. So this is usually done for vocal cord palsy, and this is a temporary procedure. We also do a medialization thyroplasty, that is to make a window in the thyroid cartilage on the paralyzed side and put a celastic wedge, which helps to medialize the vocal cord. There is also another procedure called the arytenoid adduction. This helps to close the posterior glottic gap in case if there's a gap in the posterior part of the voice box. And this is the effect of the voice post procedure, because not only it helps in mainly this procedure was devised for handling voice problem, but it also helps with swallowing problem. You can see this is a young lawyer who is trying to talk, and whenever he talks, his voice is all his words don't come out. The initial part of the words come, the other words got escape and becomes very breathy. So you can, because within this time, and I have to handle clients, my staff. And this is him after the voice box.
I'm Advocate Abdul Shuman from Bangladesh. She's my consultation is waiting for me.
So he's confident after the procedure, and he didn't have any form of aspiration. And this is a few months later.
Too much pressure on work, because in that time I have to manage my clients, my staff.
So this helps with the voice as such. And when you compare all the three techniques of thyroplasty, fat injection, all of them have very good 95% resolution of aspiration. And that's very good for the small swallowing dysfunctions. This is another patient who has had a 54-year-old male who had difficulty in swallowing solids for 2 years and had pricking sensations in the throat. And she's had multiple Gaviscon, Gelusil medicines for this, which has not helped. There's no change in speech, but she did have difficulty to talk for a long time because she was getting exhausted and tired in the throat. And she also had difficulty raising both upper limbs for 6 months. And there was some considerable muscle wasting of the muscles in the back of the neck. She was also having occasional giddiness, and she had episodes of sudden loss of consciousness, which used to come on and off. And when we evaluated her, and we also got a neurologist involved, and they diagnosed as syringomyelia with C3, C4 with Arnold Chiari malformation type 1. She also had these cervical osteophytes, as you can see here in the MRI, which these osteophytes are extra outgrowths of bone which are impeding the normal peristaltic movement of the esophagus, and you could also see the Allen-Cherry malformation. And both this was causing severe distress and dysphagia for her. Also, the odonophagia. So she underwent a foramen magnum decompression and also anterior osteophyte drilling. And this is a very unique case because we put her in prone position, operated in the back of the skull, and that is over here, you can see. And then we turned her over, and thanks to credit to our anesthetist, we turned her over, and then we removed the osteophytes, which you can see here. You can see this sharp spike like osteophyte, and this is causing constant pricking sensation whenever she had a solid food. And what this will do is also would cause some form of stasis of food as she swallows. You can see when she's swallowing, you can see there's multiple bumps. That is the bumps caused by the osteophytes and also the stasis of food. And you can see here in the anteroposterior view of the fluoroscopy. Once we removed the osteophytes and after the foramen magnum decompression, she was very good, and she was back to normal eating without any complaints. This is another patient who had a traumatic head injury and vocal cord palsy. You can see how these patients aspirate. There are two types of aspiration. Either they have something called a secondary aspiration, which you can see here. This is a food bowl has been given, and you can see the food slowly starts to trickle down during the thing. And some of them are silent aspirators. They don't cough. They don't have a cough reflex. That is very dangerous to have these patients in the ward because they'll keep getting recurrent attack of chest infection, and they have to keep going to ICU. They desaturate. So you need to identify these patients more quickly. So if we want, after the thing, when we get the scope really lower down into the trachea, you can see the food residue within the trachea there. I'll just speed up the video a bit. So you can see the green food residue in the trachea. So this is secondary aspiration, where the food hangs around the larynx and then spills over. And this is primary aspiration. There's a patient who is aspirating on his own saliva. And this is also not very good because if the saliva does contain a lot of bacteria and they don't have very good oral hygiene, they're going to have, again, repeated episodes of chest infection. So primary aspiration, secondary aspiration, both these can cause problems even to a normal ward patients and ICU patients. This is a very interesting case where a patient has pill dysphagia. He swallowing pills, and you can see how this tablet gets stuck in the back of the throat. And these are the situations where a patient is hypertensive or diabetic or an epileptic. We give them a tablet and we think the patient has swallowed it, but then the patient is not. And you can see the pill is getting stuck there in the throat. You can see the pink color pill going there and they're getting stuck in the pyriform fossa. And the patient has it there. And half an hour later, the patient just cough everything out and spit it out, and that's the end of the pill. So patient would have had his recommended dosage for that, and he will keep getting repeated seizures, or his blood pressure will not be controlled, and we will end up increasing the dose of the drug. And this is called pill dysphagia. So they have dysphagia to pill, and we noticed in this particular patient, and we tried different maneuvers. We even pulled out this Ryle's tube to make sure allow the pill to go down. And after around 15 to 20 times, he swallowed, finally the pill went into the upper esophageal sphincter opened and it went down. So why do the patients have pill dysphagia? They may have something called a cricopharyngeal spasm. That is a spasm of the upper esophageal sphincter, and this can cause this can come and go. And they can have problem for one particular foodstuff. They can have the spasm is very common for patients dysphagic to liquids, and for solids. When the patient is dysphagic to solid, they may have a stricture. So if there's a stricture, patient will be more dysphagic to solids. If there's a spasm, patient will be more dysphagic to liquids. You can see the pill there, still in the right pyriform fossa. I'll move to the next one. This is after he swallowed. The pill is gone. Okay. So cricopharyngeal dysfunction is pretty common, found in multiple neurological patients with multiple neurological issues. They can also have cricopharyngeal dysfunction after laryngectomy surgery also, when the myotomy is not done properly, and patients also with recurrent gastroesophageal reflux. So how do we manage that? We try different swallowing therapy maneuvers like the chin tuck and different maneuvers. If the patient is not able to overcome these problems with regular therapy maneuvers, then we try injecting Botox into the cricopharyngeal muscle. And this is a picture of a patient where I'm injecting the Botox to paralyze one part of the inferior constrictor or the and the cricopharyngeal muscle on one side. This is an EMG guided injection of the Botox to help with the normal swallow. So this is a patient who was had a stroke, and then he had nasopharyngeal cancer, for which he underwent radiation therapy. Stroke he had like a few years before that, and after the radiation therapy he could not swallow at all. And many people thought he had stricture. For 10 years he never ate anything, any food, and he was also on a peg tube dependent for 10 years. And when we evaluated him, we found that he had actually a cricopharyngeal spasm, no stricture. So what we did was, after injecting Botox, he could swallow, and he had waited 10 years to have his idlis. So that was a big thing, and he was very, very happy that we were able to overcome his dysphagia, which was just misdiagnosed for 10 years. In case Botox doesn't work, if patient is refractory to it, then we do endoscopic cricopharyngeal myotomy, where we find out that the muscle which is in spasm, that part of the muscle is cut, and that part of the cricopharyngeus is cut to release the spasm. Sometimes the muscle also grows back, so we do a cricopharyngeal myomectomy. This kind of procedure is done either with a laser or with a robot. And so this is cricopharyngeal myomectomy, where a piece of muscle is taken off and then it's sutured. The defect is sutured with the robot. This is a piece of muscle which is taken off. External cricopharyngeal myotomies also can be done if there's a huge a pouch, or if there is a extensive spasm of the thing, lower upper eastern sphincter, and it goes through the neck, and we can cut the muscle off. So there are studies that report that at least 50% of amyotrophic lateral sclerosis patients have improved at 6 months after a myotomy when regular maneuvers don't work. And patients with Parkinson's disease also have been treated with cricopharyngeal myotomy. And it's the prognosis is very good in terms of with regard to dysphagia for these patients. Because of this cricopharyngeal spasm, patients can have something called a Zenker's diverticulum or Killian dehiscence, which we would have read in our MBBS, and not many people in India have seen this problem, but it's quite frequent among the Western white population because of their diet rich in red meat, and this usually happens in those patients. So as this is a barium swallow where you can see the pharyngeal pouch or a Zenker's diverticulum, and by external approach we can dissect the pouch out and then resuture and help relieve him of the dysphagia. Dysphagia due to structural abnormalities. Now, if a patient undergoes a cancer surgery, and this is a patient who has all his tongue and his jaw taken out, and it's going to be reconstructed with a flap. And in this situation, the normal hyolaryngeal excursion, that is the process where the larynx moves up to tuck itself under the tongue to protect from aspiration, that normal physiology is gone. We do put these hyoid suspension sutures to help do the normal hyolaryngeal elevation. And this is very commonly done in, this is a technique which we use for cancer reconstruction during the time to help the patient swallow. And you can see the patient have got hyolaryngeal excursion. And this patient has had his full jaw removed and is reconstructed with a fibula bone flap. It's a flap taken from the leg and put in the mouth. The biggest problem with head and neck cancer patient is the radiation-associated dysphagia. When the patient undergoes radiation to the head and neck region, there are 3 different processes happen. One is acute phase where there is severe edema and pain. The chronic phase is a few weeks, a few months later is the fibrosis which sets in, which makes all the structures very tight and atrophic, and also late denervation when even the nerves are also got fibrosis, so the sensation in the oropharynx and the larynx is reduced. There are a lot of different techniques to identify and reduce this radiation-associated dysphagia, but there is dysphagia still persists, and it will end up, patients can end up having strictures. And strictures can be in the hypopharynx, postcoracoid region, oropharyngeal region, and the nasopharyngeal region. And one of the commonest ways to manage these strictures is to dilate them. And how do we dilate? We use it under endoscopic guidance. We can use the balloon and dilate the stricture. Here you can see a postcoracoid stricture at the level of upper esophageal valve where 2 balloons are inserted. And over here, there's just a single balloon which can dilate the stricture. Now, this is a very scarred area, scarred tissue. And we try balloon dilatation, and we can do for a certain period of time. But again and again, if the stricture keeps forming, then we have to resect the stricture. And this is a technique where there is a complete pharyngeal stenosis at one end. We try to identify the level of the stricture, which will be in the neck, and surgically we can cut off the stricture segment and use some sort of flap to resurface and widen the lumen of that segment so that the patient can swallow easily. So here's the patient with the pharyngeal stricture. You can see that these patients had a laryngectomy and then has had a flap surgery, but it is all stenosed down that they cannot swallow. And then the new pharynx is there, and they're really struggling to push the food down, but they're not able to do. And you can see the side view, when they turn the head with a one particular manner, a little bit of the food trickles down to the chest, and you can see the esophagus open up, but they're really, really struggling. And the patient is getting more and more malnourished because they're not able to swallow. And in this situation, we do a surgery where we do a gastric pull-up, or we end up doing a flap, as I described before. We find the stricture segment, we open up, and then we insert the gastric pull-up or the flap, and then we suture it down to widen this area. Once that's done, the patient is able to swallow without any issues at all. This is the lateral view, and this is the anterior posterior view. And in case patients have caustic injection for suicide, or they try to have severe burns, or they end up having severe alkali burns to the whole aerodigestive tract, the whole of the aerodigestive tract can get strictured. So here's a patient who tried to drink who had ingested from who had caustic ingestion, and you can see the whole larynx is scarred, and the upper esophageal sphincter also is completely scarred, and the whole esophagus was scarred all the way up down the stomach and into the duodenum. So patient was almost 1 year on tracheostomy and jejunostomy tube, until she was planned for a surgery. This was sometime during the lockdown. She underwent a colopharyngoplasty, where a part of the colon was taken and transposed into the neck, and then that particular the ascending colon is put in the neck and then formed a new gullet. And this is the opening. You can see post surgery. You can still see the suture. This is maybe the first month, and the patient was decannulated off the tube, tracheostomy tube, and she also started eating. And you can see that's a larynx. The larynx is functional. It's very difficult to identify the nerves, preserve them, and then put an extra tissue into the back of the throat. This is the lumen of the colon, which is in the neck. We can see the whole colon over there. And this is the barium swallow. You can see the hostrations of the colon. You can see how when she swallows liquid, you can see it going down her chest, and you can see the contract the whole of the sorry, these two videos don't work. Yeah. So I'm almost come to the end of the talk. To conclude, one of the reasons I got interested in this, because there is so much we can do with just this one sign or symptom of difficulty in eating. And everybody is, as an individual, we need to treat these patients, because everybody has a different cause for the dysphagia, different way of healing or getting rehabilitated. Some people need more intensive exercise. Some people need some modification in their food. Some people need some kind of more surgical intervention to augment and help with their swallowing. But what everybody wants in the end is to be eating in public, eating socially. They shouldn't be going hiding somewhere and putting some food through a tube. And so a life like that can make them very depressed, demotivated. And it's also a big struggle for the family, because the carer who takes care of them has to be constantly preparing special food for these patients. And so that's what was driving me to pick up, focus on this particular symptom and the multiple different causes. And me basically being a cancer surgeon, I focused on survivors of head and neck cancer to help to, improve the quality of life. But I realized that we can also improve the quality of life of all the neurological patients and also children. And the field is actually vast and still evolving. In the end, this would be very happy to see all our patients off these tubes, both tracheostomy and feeding tube, and then eat in a social setting. Thank you so much. I hope I gave some amount of insight into the whole um, um, topic of dysphagia, because it is quite vast.
Thank you, Dr. Vidhyadharan, for that wonderful, extensive coverage of all types of swallowing disorders in adults. Over to you, Dr. Senthilnathan, for your comments and any questions.
It was a very nice and lucid talk by Dr. Vidhyadharan. He's as sincere as he was doing PG times. I remember him, very disciplined and more studious student, postgraduate. As he mentioned, most of the causes for dysphagia are neurological. At least 70% is neurological. So I have few questions. Like we commonly encounter dysphagia in stroke patients. Yeah, whether it is an anterior circulation stroke or a posterior circulation stroke, we have dysphagia, especially in the first 72 hours. That is, we call a stage of shock.
Yeah.
So we usually practice even in Malar also to put the patient on nil oral, especially if the patient comes in the evening. We put the patient safely in nil oral, nil per oral, and then once when either we put a rail tube and then we slowly rehabilitate. So that is one thing which I find it. So even if it is an anterior circulation stroke, there is a dysphagia. That doesn't mean that like if you have a brainstem stroke, have a dysphagia. Is there any difference in managing the dysphagia of solids and liquids?
It depends, because the most of the time the nature of stroke, they're not able to. There is some kind of neurological problem more in the protecting the airway. So if they're not able to tolerate their own saliva, if they're aspirating on their own saliva, then you'll end up having a tracheostomy tube. If they're okay to keep their saliva, or this, they're just holding the saliva in the mouth and occasionally swallow. That means nighttime they're not coughing, everything, they sleep. Then we can try to instill some clear fluids. We can start that. But like you said in the beginning, first few, the acute phase, better not to do anything, because they're already a little bit compromised. You don't want to start something, then end up having also some lung issues. Only the best thing I can suggest extra is to maintain very good oral hygiene. Because that one thing we forget in the ICU also, we have to get the patient, somebody should brush their teeth, or chlorhexidine, make sure they wipe their mouth constantly. Because as normal, all of us, we swallow about less than 2,000 times every day. We're swallowing a saliva, and that's constantly flushing off all the bacteria which is in the mouth. And for these patients who don't swallow, acute phase, 48 hours, there's enough bacteria growing in the mouth. And if they aspirate, that goes to lungs. And by the 5th day, 7th day, they're having some fever and some chest infection. So whatever you're doing is correct, but just add oral hygiene. That's all.
Any test to do prior to starting oral? Because I just check the posterior pharyngeal reflex, because many of them are not able to get the instructions on swallowing. So I check for a posterior pharyngeal wall stream reflex and then give sips of oral. But still they have some kind of coughing or aspiration at the end. So do you have any test to check whether they're fit to be started on oral?
So the simple bedside test is the 30 ml water swallow test. You can try. Water is safe if they aspirate also. So the thing is that if they are cognitively okay, they can understand what you're telling. Because I remember when I was working in Amrita, some of my students, the neuro patients will be like this stiff, not looking at them. Then the people will go and say, "Sir, patient not cooperative." I will say, patient not cooperative. Patient is trapped in the body, but he understands what he's saying, but he's not able to move his thing. But if the patient is cognitively stable and he's also able to move his larynx and move his mouth and opens his mouth, then you could try this 30 ml water swallow. 30 ml of water you try to give. You see if the patient is coughing during the swallow, then you know that you need to wait for some more time. Or if he swallows, then you ask him to talk. If he's talking and he's very gurgly, the voice is very gurgly, that means he's still keeping it in the back of the throat. So that also you have to hold. So this is a simple test, bedside swallow test you can do.
This is one issue that the stroke, at least we have a temporary phase, the phase of shock where we can expect some improvement, especially in the anti-circulation stroke. Second thing is Parkinson's, especially Parkinson plus syndromes, multisystem atrophy, progressive supranuclear palsy, and CBGD, cortico-basal degeneration, where the swallowing issues are very prominent. The same swallow test we have used, actually we've done a paper of comparing the swallow test, taking taking a amount of fluid that can be gulped in a single swallow, so that we use as this thing. But these are progressive conditions. So anything specific we can do other than this?
I don't know. The progressive condition, you can keep toning the muscle. If he's cooperative, the speech pathologist keeps, giving the therapy to tone the muscle. But you know that when you have one threshold, it keeps, he's not in that threshold. Again, he drops down to the next threshold. So he needs some kind of a tube feeding to help him. But for pleasure or some thing, because all of us have that asa, they smell food, you want to have something. For pleasure feeds, we call. So we can give 1 or 2 mouths and see. And those are the people we constantly keep the muscle in tone. DBS is coming into role. DBS, deep brain stimulation. There are certain indications. And I've been told, because during my time in Amrita, they just started off DBS that time. And there's one particular level where you can stimulate, then that will control the lingual or tongue pumping, the swaying movement of the tongue, because the tongue should propel the food backward, like that. But the tongue keeps moving, the food will keep collecting and you'll aspirate. So that helps during the DBS, but it's still, I don't have the full experience.
Another short question. Another degenerative is the ALS, amyotrophic lateral sclerosis, where the bulbar muscles along with the tongue is also affected. And again, I feel that whatever amount of swallowing therapy other things has not much role. So usually motivate the patient to go for a PEG tube. Now we have a patient who is on PEG tube also, but the ALS patient has got a poor prognosis on swallowing given with the therapy. And one more issue is what is the role of the posterior pharyngeal stimulation, electrical stimulation, galvanic stimulation? Is it really useful in improving the swallowing?
It's basically you're stimulating for 2 things. One is mainly the galvanic called muscle, keeping the muscle active. This thing. It's like physiotherapy for your upper limb, lower limb. The other thing is the sensory thing, that the speech pathologist will try these kind of thermotactile sensation. They'll try different warm or cold, stimulation in the mouth by using different ways to massage. And I think Ms. Padmaja might know. And also honey, you can give a taste. Alzheimer patients, demented patients, sweet taste is more, they recognize the taste more than the other taste. So you can try something sweet, some small honey, and ask them to keep swallowing. That's the only way. But it depends on how bad it is. As the neurologist how the prognosis is going to be and how much you can let go, how much you can push the patient. So I leave it all up to you.
One more is GBS. One of my professor used to say, if there is a swallowing difficulty, then the chance of patient developing respiratory distress is also very high. Yes, but that comes with the treatment, that improves with the treatment. It's a transient phenomena. But I'm worried about the Parkinson and the ALS, where in spite of the active treatment given by the speech therapist, we feel that condition is progressing.
So in that itself, there are different severities, and you need to identify who. There are a lot of screening questionnaires to identify which Parkinson you can help and which you just straight away.
Parkinson plus is more difficult. MSA and multisystem atrophy and progressive supranuclear palsy, they have very difficulty in swallowing. I leave others also to ask questions.
Over to you, Padmaja, your comments and anything you would like to add to what Dr. Vidhyadharan has already said. We're not able to hear you properly, Padmaja.
Can you hear me now? Is it better?
Yeah.
Okay. The first thing, most of my work is with the stroke patients. Like of recent, I'm seeing more of stroke patients. So when I'm seeing there, I concentrate more on the cognition. So unless their cognition is good, the swallowing is going to be difficult with them. And again, I check on the movement of their articulators, like how I said, that is a voluntary phase. either the closing, lip closure should be complete, the tongue movement, the tongue protrusion, whether they're able to elevate the tongue, the sideways movement of the tongue, and the movement of the soft palate and all that. So once that is good, and if they are articulate, if they are able to have some speech, I check on the quality of their voice. So if it is a wet voice and there is pooling of saliva, then definitely yes, there is going to be some difficulty in swallowing. Then I think Dr. Sandilnathan was asking if there is any difference between swallowing of liquids and solids. Actually, the mechanism I don't know with the medical terms, but what I have noticed is when we are taking in liquids, initially the back of the tongue and the soft palate they close, and the liquid is in the anterior portion, and then only we slowly swallow it. But when we take in semi-solids and solids, it's the total movement. There is a circulatory movement of the jaw. The tongue moves totally, and actually the whole mouth is open. So the air gushes into even the nasopharynx, and we get the smell of the food we are eating, and that is also appetizing. And then only we form a bolus, and then it is pushed in. So I think that is the difference between taking liquids and solids. And generally, with my stroke patients, I prefer trying them on semi-solids initially. Yes, to check their swallowing, I try giving this honey thick solution. What I do is I apply it on a spoon. I put the spoon partially into their mouth and see if they are able to suck on the spoon. So by closure of their lips, and when they're doing that action, saliva is induced, and I check if they are swallowing well. So for that swallowing movement, I check on the laryngeal elevation, how much it is there, at least 1 to 1.5 inches. I feel it is sufficient. They will be able to take. And initially, I start them off on curried food like mashed papaya or mixi mashed dal rice or boiled carrots or something like that, slowly, small quantities, frequently. That is how I proceed. And yeah, that is what. And oral hygiene, yes, that is very important. It is given by the paramedical staff in the hospital, but I even ask the attenders to keep checking on them, like try to clean with a small gauze rolled onto your finger, wet it, and then roll it on the tongue and all that, because they have a white thick layer always being formed on the tongue. So geriatrics, yes, weak muscles are there. So whoever patients I get, I give them a set of exercises to strengthen their oromusculature, the articulators. So once their articulation is clear, yes, the swallowing also will be good because the muscle strength is fine. So these are the points I just wanted to add. So if there's anything else anyone wants to ask,
Yeah, we have with us a physician, Dr. Amit Ghosh from Mayo Clinic, Rochester. Amit, would you like to say anything?
Yeah, I'm actually in a meeting. A great talk, and I really enjoyed listening. For me, because I'm a physician, I see a unique form of patients, and we actually differentiate between oropharyngeal and esophageal dysphagia. The oropharyngeal is what Dr. Vijay Kumar mentioned. We see a lot of fair amount of zinkers here, so that is a cause. We also take the history whether there is difficulty swallowing liquid or solid, and usually the neurological causes like myasthenia gravis and others. Usually, initially they present with difficulty swallowing liquids. Of course, with the surgical causes, there's obstruction. There's of course there's limitation of solids more than liquids. But there are a couple of things that we see in the medical world here. This a condition called eosinophilic esophagitis. Young people with asthma, allergies, they end up getting a fair amount of dysphagia to solids. They don't lose weight. And the treatment is oral prednisone in the form of, instead of the inhaled prednisone, which you take in inhalers, the same thing we ask them to swallow. And of course, some of them would get dilatation of the esophagus to help. The other thing which we see is you mentioned about the pill esophagitis, the pill dysphagia, we also see what is called the pill-induced esophagitis, especially in patients who are taking doxycycline kind of medicine, doxycycline, tetracycline. We also see it with medicines like bisphosphonate, like alendronate taken for osteoporosis. These patients, they take the medicine and they lie down and they need to stand up. They need to be upright for 30 minutes after taking the medicine. That causes irritation of the stomach, of the esophagus. But this is a brilliant talk. We are benefited at the Mayo Clinic because we have a very good swallowing evaluation team. We have a lot of physical therapists. We do the video swallow evaluations and the chin tuck technique. I've seen several of my patients get to it. But I need to applaud the talk because the kind of cases which Dr. Vidhyadharan handles is much, much more complicated than the medical group of patients that we see, and where really they need this expertise of a surgeon. It reminds me of what I was told when I was joining medicine by a surgeon. He says, Amit, remember, always bow down to a surgeon because surgery starts where medicine fails. And this is an example of what a brilliant surgeon can do and how you can help. But I would suggest that there's only a small number of patients who would need the surgical management. Dysphagia in different forms are very common in medical practice. We were never taught about this in either in JIPMER. And when I went to PGI, I saw a lot of caustics. People are trying to kill themselves with drinking all those things. So it was more of a interesting case rather than a very thoughtful analysis and description, as was brilliantly mentioned here. I'm in actually a conference in San Antonio, Texas. I left the conference to listen to this talk, and I am so glad I did.
Thank you, sir.
Because your talk is much better than some of the talks I've been listening here. And it's probably one of the best talks on dysphagia I have heard both in India and abroad. Really, really brilliant. And I need to compliment you on doing the work you're doing. This is phenomenal work for a surgeon to get to that detail about pathophysiology. And as I always talk, that when a surgeon talks medicine, he's wasting his money because he could be operating and earning more money than knowing everything about it. But this is a really brilliant, and I wish there were more people to listen to you. Thank you very much for the talk.
So thank you for your kind words, sir. But you're right, sir. The surgery can only augment what the normal rehabilitation cannot do. So we try first, like you said, the physical therapist, the speech pathologist rehabilitating. If that doesn't work, then we do the surgery augments that swallowing rehabilitation to improve the quality of life. And where we used to do truncal vagotomy for acid reflux, and then Rantac came and everything changed. So one big advancement in medicine can send surgery backwards also. So surgery, medicine, both are the same, and of course all are allied personnel also. So that's the team approach I believe in at the hospital. But thanks for your kind words, sir. And Professor Eric Moore is also a good colleague. I do read all his papers, and maybe he's an ENT surgeon in Rochester, and he's very interested in robotics. So
yeah.
I see.
A close friend of mine. Yep.
Yes,
Thank you.
Thank you, sir. Thanks.
So we also have Dr. Ponraj, who's a neurosurgeon in Goa. Ponraj, you've been logged in right from the beginning. We'd like to hear from you.
It was an excellent talk. I mean, we are neurosurgeons and we don't understand the physiology as much as he described. So it is very, very kind of an eye-opener for us, both learning the physiology part of it as well as the complex issues involving the dysphagia. I think especially from head injury patients, we often see this problem of swallowing, especially in the severe diffuse axonal injury patients, prolonged nasogastric feeding, they have these issues. I think we don't have such expertise available in our hospital. I think I would actually go through the lecture once again and I'll listen to it again on the recording. I'm sure it will be benefiting so many other people dealing with these issues.
I tried to put as whatever I could, sir, but there are quite a lot of other videos, but it just crashed my computer. So hopefully you contact me personally, sir. I'm happy to even explain certain things which I learned. That's all, sir.
So Ponraj, maybe you can have an online CME in your college, and Dr. Vidhyadharan will try and spare time to give a talk where your postgraduates and others can interact with him.
Yes.
Thank you.
So we have another physician, Ashish Deshmukh, also logged in from Mumbai, I think. Ashish, would you like to say something? Maybe not. So anything that Dr. Vidhyadharan that you felt you could not complete in the talk, anything extra that you would like to tell us in the next few minutes?
No, ma'am, the general thing is that this is even in our ENT textbooks, this is just 2 chapters. So the field is evolving, and our technology with endoscopes and different types of assessment technologies, we have instruments. We are able to understand the whole luminal part of our aerodigestive tract much better. And so if we all have the awareness, because all of us will deal with some form of, even our anesthetists will deal with some form of patients who are dysphagic. And if we are able to identify that, then we are able to improve the quality of life for our patients. And it's not just ENT surgeons, everybody needs to find, because dysphagia is a common sign and a symptom as such. Sometimes even among our own family members, you might find suddenly some elderly person in the family saying, yeah, I used to eat this food, but now I don't eat this anymore. You have to ask why, what happened, what's the reason? Not just because they don't like it, maybe they found a way they cannot have it anymore or enjoy it.
One question from is there a role for a prokinetic agent in oral dysphagia? Because in post-stroke patients, we start with itapride and we continue it till, as Padmaja madam said, like his cognition has improved. But what I learned from my seniors is, like post-stroke, whether he's in Ryle-Strib or other this thing, we start with prokinetic agent. Is it really useful in the pharyngeal phase and the things, or only in the gastric phase?
I think it's more the gastric phase. Pharyngeal phase, I'm not, it doesn't make pan D we give, that doesn't make any big difference. But the gastric phase, because you don't want the food to be stasis in the stomach for a long time. And that could leave acid reflux, that can cause worsen things also. And
the other thing is pyridostigmine, off-label use. Is it really useful? Because again, we are using that at least 60 milligram half thrice a day, but it's off-label use only. I just got it from my seniors. Either you start with pyridostigmine.
I don't have that experience. I only used it in the rats and pharmacology lab.
Because in my senior, most of them it's a bulbar involvement, where the pyridostigmine we give and get a good results. So we have tried in few cases also with good results, but none of the publication, I don't have a standard evidence-based medicine to say it, but it actually helps in that acute phase. This pyridostigmine is particularly for the bulbar. As I told earlier, the prokinetic agent is mainly for the stomach and this phase. But for the pharyngeal phase, I think pyridostigmine may help, but
so that's
I don't have an idea.
There's a magic thing to help with the rehabilitation will be great. They don't have to keep coming multiple sessions. One tablet done, go home. So I don't have the experience.
Because we are facing this problem a lot. Immediate stroke, though it is like especially a large MCA stroke, when they are so depressed, though the brainstem is normal, all the brainstem reflexes are lost. So I tell them, if they come in the evening, I tell them to put on nil oral. But it's like we don't know when to start with oral and when to this thing. So that's why it usually takes 72 hours for the pharyngeal reflex to at least recur properly. So till then, we have to be very careful for the risk of aspiration.
See how he tolerates the saliva. That's the main. If he can tolerate saliva, and if he has a tracheostomy tube, that's the first should come out. If the tracheostomy tube has a lot of problems, because tracheostomy tube.
No, it's an acute stroke, so we may not go for tracheostomy in early stages.
Yeah, so the long-term patient.
That's all.
Thank you.
I have one question. Hello.
Yes, Ponraj, go ahead.
I have a close relative who underwent a laser cordotomy, vocal cord excision. So after that, she has recurrent episodes of aspiration.
Yes,
Do you
sir.
think it's anything related to the surgery or retraction or anything like that?
So she had cordotomy or cordectomy? Sir?
Cordectomy.
Okay.
Yeah.
So if there is a cordectomy and if there is if you actually see the voice box, if there is a glottic gap, the gap between both the existing true vocal cord and the other one remnant cord, then there could be a chance that they're aspirating. We can teach them some exercise maneuvers to help, that's the supraglottic maneuver, those maneuvers to help overcome that. And these are called the rehabilitative compensative maneuvers. If that doesn't work, then we might have to bulk up that particular cord. And how do you bulk it up is what I showed, some kind of injection, laryngoplasty, all that. But we have to find out the reason for the cordectomy. If it's a cancer, then we need to make sure they're out of that, surveillance time. Otherwise, anything we inject will kind of mask the recurrence also. We have to make sure that. So some kind of swallowing therapy will help them. And if they may be dysphagia to one particular foodstuff, mainly it will be liquids. So that's the thing, sir.
Thank you.
Thanks.
Yeah. So Amit has posted in the chat box that fungal dysphagia is common in transplant and HIV. I suppose it must be fairly common in patients with malignancy also, isn't it?
Yes, fungal, yes. Candidiasis dysphagia, yes, it's very common post radiation. And that's because of the saliva drying up and they get fungus growing there. And that's usually a bit painful and it'll be red all over. When you put the endoscope, you can see patches of white and red. So we give candid mouth paint and we ask them to, swallow that and that helps coat the back of the throat. And usually 2 to 3 weeks, they should get better.
Dr. Ashwini Kumar, would you like to say something, sir? If you want to speak, please unmute yourself, sir. I think there's something wrong with his connection. So, Padmaja, I'd like to come back to you. Anything you'd like to add?
Nothing, ma'am. Actually, it was a very illustrious talk for me. I learned a lot from this also. More of the surgical part, like things can be done. It's I think the latest. And as Dr. Vidhyadharan was saying, even when I studied, dysphagia was not really into the thing, nothing much. We didn't learn much. But over the years, with practice, that is how I learned. And with the recent articles and all that, it's being given more importance. And more cases are being referred to me, especially to check on their swallowing.
Dr. Ashwini Kumar, were you trying to say something, sir?
It is very urgent and not commonly seen the procedure and operative procedures in institutions. So it is a first time I am learning so much in detail the movement of vocal cords and pharynx. Very, 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 very much encouraging. Yeah. And I believe that so much work has been done to enlighten the medical fraternity. It is commendable. It needs more research.
Thank you for your kind words, sir. It's been the endeavor of Marvelous Medicine to bring what's happening in various fields of medicine, because normally these things will get, Dr. Vidhyadharan might have presented something like this at various ENT conferences or maybe a core group of deglutition experts. But you and I and everyone needs to know what's actually happening, because like Dr. Vidhyadharan said, it could be happening in your own family. Like Conrad said, I have myself faced this challenge at home with my husband. So I think awareness that there can dysphagia should be picked up early, and that can there is a lot that can be done non-invasive itself. And then if everything fails, there are even surgical treatments because even the acceptance for PEG or even Ryle's tube is very low with the patients, even if they are having both the family and the patient, like Dr. Vidhyadharan said, because of social and stigma. Sometimes they refuse, and then they go into severe malnutrition, and And then after that, it's a vicious cycle and things just go bad. But fortunately now, at least the acceptance for PEG is going on, but it's heartening to know that there are patients who can actually come off PEG. So maybe if we start counseling patients after actually finding out what is wrong with them, probably video assessment or whatever, and then tell them that this is to overcome the problem and that there is hope that it can actually come off one day. Maybe that will really help both the patients and the physicians, because otherwise normally you say, oh, patient is quite old, so it's okay, like, they can go home with an NG tube, and I mean, only the caregivers at home know how much difficulty is there. It's very easy for us to, as physicians or intensivists in the ICU, to say that patient's totally fine, they can go home now. What is there? One Riles tube is there, one catheter is there. They don't need to be in hospital. But the challenge that the caregivers face at home is completely different, and the Riles tube itself is a risk for aspiration. So so many things. So I'm extremely thankful to Dr. Vasanthi Vidyasagaran, who introduced me to you, and thank you so much for immediately accepting to give a talk. And I'm so glad you chose this topic, because when she said you're a head and neck surgeon, I thought, okay, you're going to maybe talk something on that, but this is something so different and so useful. And like Amit said, I just wish that we had more people listening in, but we would definitely share the video, and I'm sure it will benefit a lot of people. And Dr. Vidhyadharan, we'd like to have you back sometime in the next few weeks or months to speak on some other topic. Thank you everyone for logging in. We'll meet again next week with yet another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Good night. Thank you much.
Thank you.